We are getting ready to get started. On your cue, Laura.
Just so you understand, it's setting up the stream. I have a card on screen that tells everyone we're going to start shortly. We're only 2 minutes behind.
Okay, you give me a verbal prompt. I'm staying quiet until you tell me we're ready.
According to this,
and please check the live stream.
Ladies and gentlemen, we are streaming.
Well, welcome everybody to this historic virtual public forum.
Laura, you've got some feedback coming from your room. It sounds like somebody's got the feed on a speaker there. If they could turn that off or put it on earphones, that would be great.
Is this okay? All right. Sorry about the feedback there, guys. All right. Welcome to this historic public forum on what our government needs to do to address the urgent needs of people with disabilities as part of its emergency planning for the COVID-19 crisis. My name is Laura Kirby-McIntosh, and I'm the president of the Ontario Autism Coalition. I'm co-anchoring today's virtual forum with David. Over to you.
My name is David Lepofsky. I'm chair of the Accessibility for Ontarians with Disabilities Act Alliance, and I'm also a visiting professor at the Osgoode Hall Law School. Laura?
The Ontario Autism Coalition and the AODA Alliance teamed up to bring you this virtual public forum. The OAC is a grassroots political advocacy group dedicated to fighting for better services for autistic people and their families.
The Accessibility for Ontarians with Disabilities Act Alliance, or AODA Alliance, is a nonpartisan volunteer coalition at the grassroots in Ontario that advocates for accessibility for people with disabilities to make our society barrier-free for people with all kinds of disabilities.
So thank you for logging in to be with us today. We want to thank our excellent speakers for their time. And David and I especially want to thank Bruce McIntosh, my husband, for all his organizational work behind the scenes, especially with the backroom tech needed to make this happen. He may be whispering in David's ear remotely or yelling at me across the room today, so please bear with us. Today, we want to share ideas with our government on what they should be doing during this COVID-19 crisis to protect the urgent needs of people with disabilities. We hope government officials are watching and taking careful notes. We hope the media will amplify the important questions that we are asking of our government. And we hope the public will watch and be ready to use the action tips that we'll offer at the end of this forum. The truth is, as David always says, everyone either has a disability now or gets one later. These issues matter to all of us. In the COVID crisis, all citizens turn to their governments for the leadership we desperately need to save our lives and to protect our health, safety, and livelihood. We want to acknowledge that governments at all levels are working long days and nights on this crisis, with circumstances changing by the hour. It's not easy. There are over 2.6 million Ontarians with disabilities and over 6 million Canadians with disabilities. Government emergency planning must address the urgent needs of all those who will disproportionately bear this disease's hardships. Seniors and people with disabilities are the most vulnerable to the dangers of the COVID crisis. Whether or not one is a senior, those with fragile or compromised medical conditions are especially at risk. People with disabilities are more likely to suffer the harshest physical impact of this disease. Just look at the tragic fatalities in nursing homes we've been hearing about in the news recently. Those living there are typically, if not entirely, seniors with disabilities. Isolation at home is vital for everyone to contain this virus, but isolation at home creates additional hardships for some people with disabilities. Eliminating all close contact with others may be impossible. The much needed cancellation of school and daycare is tough on all kids. For children with certain disabilities, this can be even harder, destroying the routine that they so desperately need. a disproportionate number of people with disabilities live at or below the poverty line. They don't have the savings to survive the financial nightmare that we're facing. The homeless too often include people with addiction and or other mental health conditions. They don't have a home to go to self-isolate. So as this crisis gets worse, we will rely more and more on our healthcare system. Our governments are planning for a major surge in demand for hospitals. Yet for years, patients with disabilities have faced far too many barriers in the healthcare system. David, what has the AODA Alliance been doing so far during the COVID crisis?
Well, as we always do, we try to point out where there is a need for action and to offer constructive solutions. So over 2 weeks ago are you not hearing me?
There's no sound for him. Oh dear.
He's on. He's got sound.
I'm not sure.
My controls say that I am not muted. Can you please check your controls?
Okay, guys, stand by. We're having some technical difficulties with the sound. We'll just try to get
Please stay
David
tuned.
synced up here. We're not sure what's happened. So sorry.
I am not muted.
Oh, I can hear a little
You are
bit.
not muted, but we cannot hear you either.
I don't know what's going on. Do you want me to log out and log back in?
If you need to.
Well, you tell me what to do.
I think that's the only thing I can think of at the moment, unless you can sort of sort through your microphone and earbuds and everything else.
Okay, just give me a moment.
It's so weird. It was fine before.
Okay, let me try to log out and log in. Just give me 1 sec. Actually, let me try one other thing. Stay on the phone.
Yeah.
Okay.
Well, folks, I guess this is part of the new reality, right?
Can you hear me now?
I still can't hear him.
Okay, let me try
All
this.
jumping over to things like Zoom meetings, and there's a lot of technology going on here. We've got Zoom going on YouTube.
Okay, I'm going to log out and log back in.
Just bear with us. Sorry. I'm removing the sign for sorry.
He was logging out and coming back.
Okay. David is going to log out of the meeting and then log back in. But we really can't do this without him. So I guess what I can do while we're waiting for that is just tell you a little bit of the background about how this came about. David and I have been friends now for about 2 or 3 years, and we were both really struggling at the beginning of the outbreak of this crisis with what we could do to help the disability community. I work specifically in the autism space, but David does a lot more work, and he was able to gather and connect with all of the other leaders that you're going to meet on the forum today. So David, I can see you again. Can you try talking, and let's see if we can hear you? I see a little sign that says connecting to audio. You just have to unmute him, Bruce. And I think we're good.
Can you hear me now? Can you hear me now?
I hear him on
Oh, yes. Okay. I think we've got him.
Hold on. Can you hear me now?
Yeah.
You can hear me now?
Well, no.
Yes. Yes.
Okay, good. I'm afraid that people didn't hear what I had to say before. So let me
you better go back and say those things.
All right. So first, hi, everybody, and welcome to the world of technology. My name is David Lepofsky. I'm chair of the Accessibility for Ontarians with Disabilities Act Alliance. I'm also a visiting professor at the Osgoode Hall Law School. The AODA Alliance was founded in 2005. We're a nonpartisan grassroots coalition of people with disabilities and everybody else who wants to support us. And we advocate for accessibility and a barrier-free society for all people with disabilities. You asked me what the AODA Alliance has done in the face of the crisis facing people with disabilities during the COVID pandemic here in our community. Well, we always try to point out where there is a need for action and try to offer constructive solutions. So back over 2.5 weeks ago, on the 20th of March, we made public and widely publicized an update which identified the serious disproportionate impact that the COVID pandemic is having on people with disabilities. We called on all levels of government to take action to actively plan to address the urgent needs of people with disabilities. We offered concrete suggestions and we urged governments to reach out to us and to the broader disability community at the grassroots to partner with us on figuring out how to solve this crisis. 5 days later, on the 25th of March, we wrote Ontario's Premier, Doug Ford, repeating this message and offering more concrete ideas. Now, unfortunately, none of the line ministries in the Ontario government, that is to say, the ministries that do, excuse me, the direct planning in this area have responded, have reached out to us in any way. We've not heard from the Ministry of Education or the Ministry of Colleges and Universities or the Ministry of Health, for example. We've had some informal conversations with the Ministry of Accessibility, which we appreciate, but that ministry is more, doesn't do the actual direct operations in the areas where we need action. So we've tried to offer ideas. We've urged the government to come forward and do a policy forum like this. And when that wasn't forthcoming, we decided to partner with the Ontario Autism Coalition to do it ourselves. Laura?
Thanks, David. Of course, we're not saying that government is doing nothing, but whatever they are doing or whoever they're talking to, we want to know and we'd like to help. So therefore, in a huge rush, we've organized this virtual public forum to give governments, especially the Ontario government, advice on what it needs to do now for people with disabilities during this crisis. Now, we cut them a lot of slack because we know this is such a difficult time. But we also know from long and bitter experience that over and over, the needs of people with disabilities risk getting left out unless we are actively included and unless we speak up with our own voices, especially at times of crisis. At times like these, the maxim, "nothing about us without us," is vital. And this public forum is the first word, but not the last word, on what needs to be done. We're going to touch on important issues, including hardships people with disabilities face in the healthcare system, in finding safe shelter to isolate, in getting enough money to stay alive, and in being able to receive an education while they must shelter at home. We've lined up some great experts to tell us what special hardships they know about and what priority actions they would recommend to government. We invited the Ontario government to send somebody to let us know what they are doing during this forum. We regret that they did not do so. So we're going to turn to our first guest to talk about equal access to healthcare for patients with disabilities during this crisis. Our first guest is Robert Latanzio. He is the Executive Director at Arch Disability Law Center. Arch is a cross-disability specialty community legal clinic that advocates and advances equality rights on behalf of low-income persons with disabilities across Ontario on different legal issues. Welcome, Robert.
Hey, Robert.
Hi there. Good morning.
Good morning. So we know that right now there's going to be, or there is a surge of demand for emergency medical services as more and more people are getting sick from this virus. Can you talk to us about the impact that this threatens for people with disabilities?
Definitely. Thank you, David. Just a quick thank you to our hosts and everyone organizing this event, a really important event and done in such short notice. So thank you. Our starting point on that issue, David, is really that COVID-19 is truly disproportionately impacting marginalized communities. We know this. Moreover, some of our communities of persons with disabilities are more vulnerable to the COVID virus. Most systems and emergency response plans do not contemplate our communities and their accommodation and support needs. And this, of course, is layered on an already inaccessible healthcare system, systemic discrimination, and a history of exclusion and marginalization. And lastly, we have to keep in mind that the important and critical response measures for COVID to deal with the outbreak of COVID and this pandemic is, or measures like physical distancing are simply impossible for many persons with disabilities. So taking all that, and we also know that as our healthcare system continues to be increasingly burdened, and if we don't flatten the curve, there will come a time, and that time may be very near, when very difficult decisions will need to be made. These are decisions about life and death. The Ontario government has developed a draft document that provides a framework for how decisions will be made by healthcare workers to ration critical treatment once intensive care units in Ontario are about 130% capacity. And so I'll be referring to this document during my talk, and I'll just refer to it as the Triage Protocol. So we've reviewed the protocol, and ultimately this protocol is set up to guide last resort decision making for scarce critical care resources. So I want to raise several key concerns that we have about the protocol. So the protocol effectively deprioritizes persons with particular disabilities, such as cognitive disabilities and advanced neurodegenerative diseases, including Parkinson's disease. Persons with disabilities who receive accommodations and supports from others for activities of daily living will be, in some circumstances, deprioritized from receiving critical care. And the triage protocol has the effect of including value-based judgments about disability and the quality of life, and discriminatory views about living with a disability. Lastly, the triage protocol doesn't include any mention of ensuring accommodations and support, such as communication accommodations when providing critical care or making decisions about critical care. In appreciating the extreme difficulty of a scenario where, for example, one of two individuals will receive a needed ventilator in a hospital, that decision will always be a devastating one. There is no clear answer to a question like that. There just isn't. But what is clear, however, is that any decisions cannot ignore fundamental human rights. Such a decision cannot be informed by whether someone has a disability or any other protected characteristic, and what people may think about how that characteristic or how that disability impacts their quality of life. We also need to consider the impact that this type of protocol or this actual draft protocol can have at the various points of contact that persons with disabilities would have in trying to access needed health services. For example, first responders like emergency medical technicians and paramedics will be making some really, really important decisions which will impact whether people even make it to the hospital. At hospitals, if folks get there, nurses providing critical care, frontline care, will be really, really pivotal in terms of the information that gets to a doctor. And then ultimately the doctor, makes that decision, that critical decision about whether particular critical treatment is provided. All along the way in this chain of events, these decisions can have really devastating impacts. And the triage protocol will influence those decisions. And so the protocol will influence it whether directly or indirectly. This is real. It is happening. We know it's happening in other countries. We know it's happening all over the world as we speak. There are protocols on last resort decisions and triaging being used and adopted in other countries. Some of them are similar to the triage protocol that I'm referring to. Some of them are expressly worse, and some are better. And we can do better. We must do better. So here's what we need, or at least here's some of what we need. First, we need a framework that focuses on questions like, will the ventilator save your life? That's the question, right? Decisions need to be based on clinical judgments regarding the person's short-term survival associated with COVID-19. That's it, nothing else. Second, we need a clear and explicit statement that reaffirms human rights principles and expressly states that any decision made will avoid discriminatory value-based judgments about living with disabilities. Disability or any other identity and characteristic protected in our human rights code, it can't be deprioritized. People cannot be deprioritized from services within this decision-making process because they identify with a protected ground. We know that. Those are our fundamental human rights. Third, we need a clear and explicit statement reaffirming the rights to accommodations and supports such as communication, supported decision-making, and other really critical and important supports. And fourth, disability communities need to be at the table in developing this framework. Our healthcare workers are working incredibly hard at the front lines, and we appreciate the extreme difficulty and pressures on our government that this health crisis is creating. But we ask our government to reconsider. There is currently an open letter circulating urging for protections, and I ask you all to consider signing it on behalf of your organization if you have a legal authority to do so. And we ask that you do so by 3 p.m. today. ARCH and the AODA Alliance and many other groups and organizations have supported the letter so far. So to sign it, you can access it on our website at our homepage at archdisabilitylaw.ca. And maybe one last plug here. You can also reach us for free confidential summary legal advice if you're experiencing barriers and discrimination during this health crisis. We also learn from you about any new and emerging issues or barriers from your calls, and this is ever more important as things are moving and developing so fast. So I wish to thank you in advance for your support in raising our collective voices on this critical issue and the other issues that we will be discussing today in this public forum. So thank you very much.
Hey, Rob, thank you very much. And if I can, Ontario Autism Coalition is also a signatory of that open letter, just so people are clear. 3 of the organizations, in fact, a number of the ones that are on this conference or on this policy forum will have signed by now. And we appreciate your efforts at bringing those signatures together. The bottom line is this. Those making decisions over whether a patient goes to hospital, gets admitted to hospital, gets care in hospital, gets emergency care, gets ration care, should not be based on a healthcare provider deciding that the quality of life that they would live if they survive is not, in the view of the healthcare provider, not as good because they have a disability. Those kind of stereotypes about our lives have no place in any decision at any time over healthcare services, and especially not over critical and life-saving healthcare services. Thanks very much. Back to you, Laura.
Sorry, forgot to unmute there for a second. So we're now going to turn to Jane Mevis. She is a staff lawyer and institutional advocate with the Advocacy Center for the Elderly. ACE is a community legal clinic that advocates for seniors in our community. Jane represents low-income seniors in long-term care homes, hospitals, and other congregate living facilities on issues related to living in those facilities. Jane has, among other things, specialized in advocacy for seniors in institutional settings like nursing homes and homes for the aged. So welcome to Jane.
Jane, thanks so much for coming. Tell us, what are you hearing and what are the big challenges or added hardships facing people with disabilities and particularly seniors that you're dealing with living in institutional settings like nursing homes?
So of course, the biggest problem that we're having right now is that the largest number of deaths are seen in long-term care homes. And there's a number of reasons for this. And it has to do with the structural facilities, the number of people that are coming going within those facilities, and the inability to ensure that people who are in those homes are not being spreading the diseases. It is very difficult in long-term care homes to socially isolate. In fact, if you're in a 4-bedroom, it's probably impossible. People with dementia, you can't simply just sort of tie them to their bed and say, don't go anywhere. And so there has been very little planning on how to prevent the spread of the disease within these homes. It was really late to the game, I think, that workers were even getting proper protective devices. They weren't wearing masks until very recently, unless there was an outbreak. So all of this has gone to, unfortunately, make it so that people in long-term care have been very susceptible because of their immunity, other kind of comorbidities. So we're really seeing a big problem in the long-term care homes. And for people living in long-term care homes who want to protect themselves, I don't think there's a lot that they're able to do. We're also seeing a real issue around having people taken to hospital from long-term care homes. Many long-term care homes have people sign documents when they're admitted, and these documents are often called a level of care form. And we're seeing those being utilized in a way where they shouldn't. The homes aren't talking to family members. And in fact, we're seeing public officers of health, administrators, and doctors in homes basically saying that they're not going to send anyone to hospital anyway.
So wait a minute, Jane, it's David. Just tell me, so who's making the decision not to send them a patient who's sick to the hospital from a nursing home?
So many of the homes have actually said that they will not send patients to hospital. The Minister of Health and the Chief Medical Officer of Health have both said that there is no directive for that. However, that's what we're seeing, is that homes are more and more saying that they're not going to be sending people to hospital. And they're also relying upon documents that were signed out of context when people were admitted to homes. Instead of talking to the resident or the family, they're not doing that. They're just simply leaving people in homes because they believe that the documents say that they shouldn't be taken to hospital for any kinds of treatments. And it's so out of context that it's quite problematic.
And so the effect of that, if people are in the nursing home, is they're either sitting ducks waiting to get the disease, or they've got the disease and there are in some cases being blocked from even being able to get access to healthcare that could help them.
That's right, and continuing to spread the disease within the house, within the home, because it's such close quarters. We are also seeing people considering taking family members home from homes, and there has been a new regulation which allows people to bring the person home. They will lose their bed. Following the crisis, they will be allowed to go back into the home. They'll get a high priority for readmission. But there's also that quandary, is if you bring them home, do you have the supports at home? There's a real run on home care. People may not be able to get any kind of care in the home. And we're certainly seeing people call us saying that the home care that they've had, so people who are already in the community are having their home care cut back.
So seniors who are living at home who need home care services, it's being cut back because there's such a high demand on it.
That's correct. Plus, people are sick. The home care workers themselves are sick, and home care workers are not getting the protective devices that they need to go into homes.
You're talking about masks.
That's a problem.
You're talking about masks and that sort of thing.
Exactly. So, it's a real quandary because people want to bring someone home, but they may not be able to do that. We also have, of course, any kind of day programs are shut down. So people who had some kind of assistance, some break during the day, that's gone. There's no respite care for people in the community anymore in long-term care.
You're talking about the family members of a senior who need some respite if they're taking care of their loved one.
That's correct. And so we're, certainly seeing that people are really going to be burning out, and that is quite concerning for the safety of the people in the community.
From this, right. So what do we do about it? Can you give us some top recommendations in the face of this that you would bring to government's attention, or you'd like government to take?
Well, I think that they really need to get some infection control specialists into the long-term care homes to figure out what they should be doing in those homes. Thankfully, they're supposed to be getting more personal protective devices in those homes. But I think that there's a really big problem that we've seen across the world with long-term care homes. And I don't think that there's been a lot of attention put by the expert on how to fix that.
Okay, so let me just go into this. You're saying that we need
Mhm.
infection control specialists to tell nursing homes and long-term care facilities
Mhm.
how to better isolate patients from
Mhm.
each other so they're not spreading it. Anybody with any experience with having a loved one in a nursing home knows that for years they've had flu bugs and other things that go rampantly through those homes. Why don't they know already?
Well, I think that's a really good question. I mean, we certainly have, each home has an infectious control specialist within the home, but that would be just usually like a nursing person, a nursing staff member that is is able to tell people about hand washing and that kind of control. We're talking about sort of a different level here now. I agree with you. It should have been done in the past. But unfortunately, nursing homes do tend to be sort of the poor cousin of the healthcare system. And, as we've seen with this, they were the sort of the last ones to be looked at around getting some of the personal protective devices that they need. And yet it's where the biggest outbreaks are.
And what other priority recommendations would you make to government?
Well, we are seeing a change in the staffing in long-term care. And I think that because there's not enough personal support workers in the community or in long-term care homes, they're now hiring unregulated staffing. And I think one of the big things is that we have to get some kind of training, proper training for those staff that are going into homes, because they often will have little to no experience with any kind of infection control. And they don't really understand healthcare. They're just being hired because there's no one else to provide the care in the homes.
And we know if we leave it to each home, then they've each got to reinvent the wheel for training these untrained staff and unregulated staff in a crisis situation. If government were to create some online training modules, or if they've got them, if they would make them widely available, then that could at least be used to make it easier and quicker and cheaper to train people in the crisis situation.
That's exactly right. Each home is doing their own thing. There's a lot of latitude being given to homes and as to how they're going to run it. And I think that's going to be quite problematic because these are the places where we're seeing the largest number of infections and deaths.
And your recommendations regarding the practice that's deeply disturbing of not even letting people go to a hospital, what are your recommendations on that?
Well, it has to be done on a case-by-case basis, and it has to be done in conjunction with the resident if they're competent or their substitute decision maker. And this has been an issue that we have been fighting against for years. And in fact, one of the protocols said that people needed to update their advanced directives and to make sure that they're understood in the homes. It's clear that whoever wrote that document didn't understand that people who are incapable can't actually do an advanced directive, so it's quite problematic. But it really has to be an understanding that it has to be on a case-by-case basis because each individual is different. There are people from the age of 18 and up in long-term care, and like Robert said, we have to look at them as individuals, not as disabilities.
And so, Laura, just finally, and Laura, we're coming back to you in a minute. What's your advice to family members of people who are in long-term care facilities? What should they do to make sure these decisions aren't made without their participation?
Well, they need to speak to the homes. They need to keep up to date. Homes need to be keeping family members up to date on what is happening on their homes. If there is any kind of presumptive COVID outbreaks, if you can bring someone home, because you're not working right now, maybe you can provide the care. That may be something you want to do, but you want to make sure that you have the ability to provide that care. But people really need to be speaking to the homes and saying, this is what we need to be contacted when the loved one is going, if they come down with some kind of an illness, and so that they can help make that decision. And it's not a decision that the administrator should be making.
Jane, thank you very much. Back to Laura.
Thank you.
Thanks a lot for that, Jane. That was really important. So we're going to broaden our focus a little bit now, looking not just at healthcare, but as well to issues of surviving while self-isolating at home. So next up, we have Wendy Porch. She's the executive director for CILT, the Center for Independent Living in Toronto. CILT is a community-based resource organization run by people with disabilities for people with disabilities. CILT is the provincial administrator for the direct funding program in Ontario, which supports thousands of people with disabilities to act as employers to hire and manage their own attendant services. CILT offers a number of peer-based programs, including supports for parents with disabilities, and manages the Attendant Service Application Center, a centralized application hub for supportive housing and attendant services in the GTA. Welcome, Wendy.
Hey, Wendy.
Hi.
Just before we do this, I want to just remind or let our people logging in know that while we're talking about Canada and focusing on Ontario, we're trying to cover issues that will recur in different ways in different communities. So we don't mean this to only be relevant to Ontario. A disability is a disability wherever you are, and this virus is all around the world. The other thing I want to remind people is that we are all active on Twitter. We encourage you to follow at AODA Alliance, and for the Ontario Autism Coalition, let me know if I got it wrong. It's at Autism, O-N-T Autism with no dots. And we've created a new hashtag if you want a live tweet about this event or about these issues. It's the $ and then disability urgent. One word, disability urgent. Wendy, your organization is involved with assisting people with disabilities living at home and who need assistance and services to be able to live independently at home. What are the particular hardships that you're witnessing that this COVID virus crisis is having for them?
That's right, David. So CILT supports people with disabilities to live independently in the community. And the reality is that people with physical disabilities, many of whom have health conditions that make them more vulnerable to severe illness if they do contract COVID, are facing barriers at all stages of the response to the epidemic. And we do need government to step up and take leadership in addressing these issues. So I'm going to talk you through some of the barriers and some of the possible solutions now. To set the context, so thousands of Ontarians with physical disabilities live in the community by accessing attendant services. Attendants are often personal support workers, but are not always, and they assist people with things like eating, dressing, using the bathroom, necessary activities of daily living. In our direct funding program, people with disabilities act as employers and hire and manage their own attendant services. Attendants typically spend a few hours a day with people to help with these tasks. There are some people who require many more hours of attendant service, and they require people to help them with things like moving through the middle of the night to avoid bed sores and using ventilators and CPAPs at home. So physical distancing is impossible in this context. So the first barrier I want to discuss relates to personal protective equipment. People with physical disabilities need access to attendant services in order to live and cannot physically distance from attendants. Because attendants may work for more than one person with a disability and may also work for long-term care facilities, attendants could be considered community vectors for this illness. Both people with disabilities living in the community and attendants need adequate personal protective equipment.
By personal protective equipment, you're talking about gloves and masks, right?
Well, it extends even further than that. So it's gloves, masks, and in some cases, face shields and gowns. But to date, this group of people have had to try to source their own personal protective equipment, which is quite difficult to understand. So in an environment where even whole countries with all of their leverage and buying power are having difficulty buying PPE, how is an individual person living in rural Ontario supposed to be able to access this equipment on their own now? It's really very perplexing. So the solution, we believe that the Ministry of Health must immediately assume some leadership on this problem and consult with stakeholders like SILT and other IL centers to find and execute the most
IL centers are independent living centers.
independent living centers, to find the most feasible solution for getting PPE, personal protective equipment, to attendant care consumers and attendants in Ontario. Now, the
Wendy,
second, yes,
Wendy, can I
Laura.
just jump in? We're just getting a question from one of our viewers on YouTube. Is SILT mandating the use of masks in its facilities?
SILT doesn't have any facilities.
Oh, okay.
So the way that our program works, the direct funding program, is that people, consumers, people with disabilities themselves are their own employers. So we have
Right.
been sharing ministry guidance around PPE from the start of the epidemic. Everything that comes out around how to use it and when to use it, we have been sharing with our participants in the program. The real issue is access to PPE. As I said, governments can't seem to get their hands on this equipment at the moment. So how is it that individuals who are supposed to be doing this for themselves are expected to be able to try and find it?
You can't go to the drugstore because they're all sold out.
Right.
And I just want to make sure I've got this clear. So we've got an attendant care worker who may work for several people during the day. They'll go from one house to the next. They've got to be in close proximity. You can't help someone to go to the bathroom or get on the toilet and stay 2 meters away from them at the same time, or turn them in their bed so they don't get a bed sore while staying 2 meters away.
Yes.
So you're going to be proximate to them. You're going from one person to the next. The folks that you serve are among those who can have immune deficiencies, can be more exposed to contract this disease.
Yes.
And so when you say the attendant care is a vector, that means they could be carrying this from one person to the next, and the people they're working with are among the more vulnerable to getting the
Precisely,
disease.
David. Yeah, that's precisely the concern that we have. You know, when we've been talking to participants in our direct funding program, they have been saying, you know, if one of us gets it, all of us are going to get this. And we're still having difficulty finding PPE. So SILT is doing what we can to support consumers with resources that we can identify in terms of accessing that equipment. But we need a better solution to this, and we need the Ministry of Health to step up and help us to sort this out. Aside from the question of personal protective equipment, we're also very concerned about barriers to assessment for people with disabilities who live in the community. So if you're suspected, if you think that you might have COVID, you're directed to go to an assessment center. But people with disabilities face barriers to even getting to these assessment centers. So, for example, in Toronto, Wheel-Trans has said that they will try to offer individual trips to individuals with disabilities who need to go to a COVID assessment center, but they cannot guarantee that.
By individual trip, you mean a trip with no other passengers in the vehicle?
Precisely, a trip with no other passengers. So let's actually think about that. You think that you might have COVID and you're trying to get to an assessment center. Maybe it's unconfirmed at this point, but you could be sitting beside somebody who does have COVID in that vehicle to go to the assessment center. So this idea that everybody has to get to the assessment center in order to be tested is very difficult for people with disabilities.
Or another way of putting it, somebody could be taking a Wheel-Trans ride because the mainstream transit system is still got too many accessibility barriers. So all they can use is paratransit. They don't have COVID. They don't think they have COVID. They've been isolating at home. They've been washing their hands. They've been doing everything they can do. But to use the only accessible transit option, they could end up sitting next to or in the vehicle with someone who's going to get tested for COVID.
Well, that's unlikely, actually, David, because what Wheel-Trans is actually saying that they're trying to do is to set aside specialized
I
vehicles
see.
that are
Well, that's
only
good. That's good.
for assessment centers. But at the same time, you know, to take that vehicle into the assessment center and to have a cold, but be sitting beside somebody with COVID, you can see clearly that there's a concern about community transmission.
Okay,
there.
that's good. And it's good that the paratransit services are doing that. Credit to them.
Yeah, but to address this, what we're suggesting is that there is an implementation of mobile testing units for people with disabilities in the community. So some people with disabilities can receive testing at home for things like strep throat or x-rays. So why can they not be tested for COVID?
So in other words, we already have the medical infrastructure for some kinds of testing at home for some other things, but what we need is to have mobile testing for COVID for people with disabilities in this situation.
Precisely. So, you know, why not take a paratransit vehicle and kit it out as a mobile assessment center and actually have it go out into the community? And while you're there and you're testing people, if somebody is positive or somebody looks likely to be positive, have personal protective equipment with you that you can then pass along to the individual so that they can recuperate at home. Because this brings me to my third issue, which is the third barrier relates to people with disabilities who have COVID and have to be hospitalized. The isolation guidelines now say that if you have COVID and you are in hospital, you can have absolutely no visitors during treatment. So people with disabilities who rely on attendants to perform these activities of daily living would not have access to attendants or family for help with that in the hospital. Now, for people whose health is already fragile, this will have dire outcomes since hospital staff simply
Okay,
do not have the time or expertise to help with this.
okay, let me clarify this because I think some of our viewers may not realize this. So you need the attendant care to come into your home to get you out of bed, get you on the toilet, help you do some of your activities of daily living. If you're in the hospital, COVID or no COVID, the attendant care the hospitals don't provide in-hospital attendant care for patients in those circumstances. Is that what you're saying?
Yes, that's what I'm saying. So the nurses and the staff there will try to do their best to help, but people in the community with physical disabilities who go into hospital arrange to have family members and attendants come in to help them when they go into the hospital because the staff there simply do not have the time or the expertise to do these things.
But with
So
COVID, we have limits on who can go in the hospital.
yes, so what we're calling on is for the government to revise those isolation guidelines to allow people with physical disabilities who rely on attendants to have them come in while they're in treatment. So what is the difference between a
Okay,
nurse or a
sorry.
doctor?
Let me clarify this. What you're asked the government to do is normally they don't. If somebody goes into hospital right now, you can't have people come in to visit you, or there are restrictions on who could come in to visit you. You want an exemption to those restrictions for people who are coming in to provide attendant care to a patient with a disability in hospital who needs attendant care.
Mhm.
Precisely, that's exactly what we're looking for. So what is the difference between a nurse or a doctor and an attendant or a family member? As long as they're screened and they're equipped with PPE,
Right.
allow them to come in and do their jobs.
And I would
One,
imagine with the
sorry,
hospitals
David,
being overloaded right now, they would really appreciate any extra help they can get.
I would think so. Wendy,
Laura?
we've got another question coming in from YouTube, and this kind of overlaps with a concern that we've got in the autism community, where normally there's a restriction on hiring family members as attendants or respite workers.
Mhm.
Let me just go to the question. Will you be addressing how individuals on the direct funding program can hire family members during this pandemic? Do you know, like, is that now being allowed, or do you have any information on that?
What I would suggest is if somebody on the direct funding program is in a position where they don't have any attendance, they need
Right.
to get in touch with us right away.
Okay.
We can have a discussion on a case by case basis about whether or not that's a possibility for them.
Thank you.
All right, other
Um,
priority actions, Wendy, that you'd like to propose?
Well, so the last one really has to do with what Robert was talking about. And I just want to summarize quickly, though, David. So, people with disabilities are more likely to get sick because they have health conditions that make them vulnerable. They have no options for physical distancing. They have regular interactions with community attendants, all of whom have no formal access to PPE. They cannot be tested without increasing their exposure, and they are not able to access attendant services if they go to hospital. Now, to add to this mess, really, the context that says that people with certain kinds of disabilities will not be offered treatment if they are hospitalized or if they require it. So we were talking about access to ventilators and access to ICU treatment. Seems to me to be unconscionable. So if we're looking at a population that is so vulnerable and that doesn't have access to the equipment that they need, and then at the end of the day, we're saying that we might not even prioritize you for treatment is not acceptable. So those guidelines have to be revised. They have to be revised in the way that ARCH has called for them to be revised in that open letter. So
Let, let me just clarify this. So what we're facing is a person, not every disability, but a person with certain disabilities is more vulnerable to get this disease.
Mhm.
And then what you've described for at least the population that your organization serves, they are then made more exposed to getting the disease because the services they need just to get through the day are the attendant care may bring the disease into their home because of the lack of personal protective equipment. So they're more exposed to actually get it by
Mhm.
virtue of that lack of that equipment. And then they end up in the hospital where there may not be the services they need and there are rules against bringing them in, even if they've got them on hire. And then if as a result of all of that, they end up facing we're in the middle of a horrible situation where there's fewer ventilators than people who need them, they could end up, depending on the protocol used for triage, which Rob talked about, being at the wrong end of the stick where their disability, there's a risk if disability can be taken into account in deciding who gets that ventilator and who doesn't. And it would seem, if I'm hearing you correctly, that the way to prevent some of that horrible pressure on the allocation of ventilators in the first place is to solve this problem before it's created through the measures you're talking about.
Yes, so if people with disabilities may not be treated simply because they have a disability, shouldn't it be considered a priority to ensure from the start that they are adequately protected?
Wendy, thank you very much. Back to you, Laura, for our next guest.
Okay.
Thanks, David. Thanks, Laura.
All right, Wendy, see you later.
See ya.
All right. So next up, we're going to speak with Barbara Collier. She's the Executive Director of Communication Disabilities across Canada. Access Canada is a nonprofit organization that addresses accessibility and social justice for people who have disabilities that affect their communication and who communicate using communication boards or devices. Thanks for joining us, Barbara.
Hey, Barbara. Barbara is one of the, if not the top experts in this field in our country, and we're honored to have you here. Tell us what kind of tell us about who you're talking about, people with what's a communication disabilities and what are the added hardships they're facing, and what should government do about it?
Okay, and this thing just keeps on layering, doesn't it? It's
yes.
The people that I'm going to be talking about who have pre-existing speech, language, and communication disabilities are very often the people who are also using attendant services. So everything that Wendy is talking about, whether it's direct funding, agency services, or relying on family members to support them, are in that position of the fragility of that system breaking down on them, and having to, on top of that, teach somebody how to provide them with the service when they have a communication disability. And they may use a communication display, or they may use unclear speech, or they may use a device to communicate, and that just layers things. You asked me who I'm talking about, so I should backtrack a bit. There's about 165,000 Ontarians who have disabilities that affect their communication. And that can affect their understanding of what somebody's saying to them, and it may affect how they speak. So we're talking about people who have lifelong disabilities such as cerebral palsy, intellectual disability, autism spectrum. We're talking about people with acquired disabilities such as brain injuries, aphasia after a stroke, ALS or Lou Gehrig's disease, Huntington's, Parkinson's. There's just an enormous spread of disabilities that can affect how a person communicates.
Okay, and you're not talking about people who are deaf or deafened or hard of hearing.
No,
in this context.
no, because there's other people who address that. I'm talking about people who have neurological, intellectual disabilities, disabilities that affect that.
Okay,
so
gotcha.
That's the group.
Okay, so tell us about the barriers they're facing.
Oh, the barriers, everything that Wendy covered, and that layering now of, I've got somebody new coming in, I need to not only teach them how I communicate, but I need to teach them how to provide the services to me. And on top of that, I need to know and teach them how to keep me safe. Now, I'd like to focus a little bit more on access to the healthcare system itself, or to the COVID process, I'll call it, the assessment and treatments, because this is a population that has a long history of problems and communication barriers with healthcare providers. At the best, there's no best time to be interacting with healthcare, but this is particularly serious. They tell us, they reports constantly about healthcare providers equating the inability to speak as having an inability to make decisions or to give informed consent. So incapacity is equated with communication disabilities. And we are trying desperately to get the message out that when a person has a communication barrier, they are not incapable. What they need are
By
support.
incapable, just so people understand, we mean that they're not cognitively incapable of understanding the choices when explained to them and making a choice. If the
Exactly.
communication disability is being able to effectively communicate.
The communication supports, the appropriate supports are required to empower somebody to effectively communicate in all aspects of healthcare, and that includes giving informed consent.
So we have that stereotype pervading before we get COVID. How does it play out now with COVID in inundating the healthcare system?
Good question. Just look at this. Effective communication is essential for all of us. So what we have now is a system where there's a hotline, okay? That hotline is a telephone line. How are people who cannot use the telephone able to use that system? Now, I want to come up with some recommendations at the end, but that's one barrier. Then you've got a triage system of an interview. What supports are there for somebody who communicates with pictures or a letterboard or a device, or requires somebody to interpret their speech and their communication? That's a barrier. You talk about then going into the hospital. How are people who have pre-existing communication disabilities able to communicate their symptoms, their medical history, all of that? Very often people are sitting in their wheelchairs and they're able to point to whatever they want. Now they're lying down. Now they're sick. Now there need to be adaptations. They may need to use their eye gaze. They may use different signals for yes and no. And this is all the way through the process.
Now, in preparing for today, you told me that beyond those who have pre-existing communication disabilities with COVID, we've got a new bunch of folks who've just acquired communication disabilities due to COVID. Can you explain that briefly?
You and I, everyone. You need breathing to be able to communicate and speak. So COVID affects your respiratory system. If you have difficulty breathing, you may also have difficulty speaking. If you're intubated and you're on a ventilator, and you may have various degrees of sedation, you cannot speak. So we need to put communication supports in place, not only for people with pre-existing speech language disabilities, but also people who become non-speaking because of COVID.
So everybody watching this who thinks for the first part of your discussion that you're talking about somebody else, not them, has to start thinking that this could happen to me too, and soon.
Absolutely.
So what do we do?
Absolutely.
What are your top recommendations to government? This is a problem that we can't totally fix in the middle of a crisis, but there are some things government can do. What do you suggest?
Okay, couple of things. And I think we can put some things in place here. First of all, a separate hotline for people who have disabilities, including people who have communication disabilities, that gives the text version, but also communication assistance to do that. And people who are perhaps speech pathologists who may not be working right now in non-essential services, who actually know how to communicate with people who have speech disabilities.
So speech language pathologists, they are a profession that are whose training pertains to this.
Perfectly. And those specialized in what's called augmentative communication, which is non-speech communication. They're the ones that can bring tremendous resources and skills into this scenario.
And so if any of them are at home right now due to the isolation, we need to see if there are ways we can draw them into helping healthcare providers while equipping them so that with protection so they don't get sick in the process.
And I see them at the assessment, at the triage, the hotline, the triage level, and then I see them deployed where they're needed.
When you say you see them now, or that's what you're recommending? I'm
recommending. They're not there. I've started to do a survey. They're not there at all right now, and people I'm surveying are saying we should be there. So we need to do that. But there's another. So we need their boots on the ground where they're needed, and we also we want an exemption to the isolation protocol. There are people who cannot, as Wendy said, go into a healthcare setting through COVID and be okay. They need attendance services, they need family support, they may have intellectual disabilities, autism spectrum. They're not going to do well in isolation. They need people they trust with them, and they need a communication assistance there.
So in other words,
I
just so
see
let me just clarify if I understand. So when you say the isolation protocol, the rules that right now prevent us from going into hospitals, if a person with a communication disability is admitted to a hospital, there should be an exemption that lets them, if they're properly screened for symptoms at the door and given proper protection, to go into the hospital so they can provide communication support for the individuals you're talking about.
With pre-existing, and have the speech pathologists on call wherever to be brought in and say, well, Johnny can't speak, cannot communicate, he can't point to his display. Tell me how to adapt that. I also see this as a separate unit. I think we have rehab facilities that this actually should be a separate unit for people who need these supports in place.
Okay, by a separate unit.
We just need to mobilize them.
Okay, again, let me clarify as I understand it. What you're saying is we know governments right now are expecting a flood of more cases in hospital, and they are creating emergency healthcare venues or certain buildings or services. And what as I understand it, tell me if I got it wrong, that you're saying is that as they create those new areas, they should set aside some of them to be specialized units where people with communication disabilities
need supported assistance. I would include attendants and families in that, not just, and communication assistance is one type.
Right, and then this is a greater efficiency for government. I mean, they're setting it up new anyway, instead of having to train everybody everywhere that this may be coming along. At the very least, on an urgent basis, we could be making sure that we have people in place for that specialized location or wing that can work, assist patients in the circumstances you described.
Or it could be a rehab facility that currently exists, that is fully accessible, that was custom built for people with disabilities, and a staff that may be now working at home or doing other work, but are trained and could actually be deployed into that.
Okay, Barbara, any other top priority recommendations you have before we wrap up with you?
I think we've covered it.
Okay, great.
There's far more, but I think I'll leave it at that. Thank you.
Okay, very much. Barbara, thanks so much for being part of it. And as with all of our presenters, thanks for the amazing work you're doing. Back to you, Laura. And I just want to note, my watch says it's 11. We initially hoped that we would finish at 11:30. I'm thinking we have to finish by noon, but we may well get closer to noon. I just want to let our captionists and our sign language interpreters and our guests know, because there's so much important content being delivered. Back to you, Laura.
Right. Thanks again, Barbara, for all of that. You've certainly raised some really important issues. So we're going to turn next to talking more about people with intellectual and developmental disabilities. And as Barbara was saying, you know, people with that situation, whether it be autism, Down syndrome, or other developmental disabilities, if they have to go into hospital without support, that's a really scary situation. So we turn to James Gennaro to talk to us about this. He's the Director of Community Engagement and Policy at Community Living Toronto. James is responsible for advocacy to all orders of government and helping our community mobilize to advocate for our issues. Thanks for joining us today, James.
Thanks, Laura.
James, tell us, your organization works with people with intellectual and developmental disabilities, and the name is Community Living. The goal of the movement for years has been promoting opportunities for people with intellectual and developmental disabilities to live in the community. Tell us what additional or particular hardships or barriers they're facing during the COVID crisis, and what you'd recommend that government do to help alleviate those particular hardships.
Great. Thank you, David. Thank you, Laura, for the invitation and the opportunity to talk about this really important topic today with such a pretty esteemed panel. Off the bat, I'll say that Community Living Toronto, there's a version of us in every community across the province. Every city, town, hamlet, big and small, there's a version of our organization supporting people with disabilities. Many of us support people in residential settings, some that we own, some that we rent, and in many situations, we support people to live independently in their own homes. And a backbone of the way our system works is that in addition to having residential programming, you also have what some call day supports, day programs, respite, all sorts of other lines of programming that are specifically designed to take somebody out of their home into the community to do something that isn't just being at home, watching TV or being with your family, that kind of thing. And the major hardship that our community is experiencing right now is that virtually all of those programming opportunities have been put on hold. For very good public health reasons. All of our day programs are closed, our respite facilities and respite programs are closed, again, under very good guidance of public health. So what this results in is a lot of people with intellectual disabilities who, again, may live at home with their parents or live on their own or with roommates, et cetera, supported by organizations like mine, don't have the option of those day programs out in the community to sort of do something different. Again, that isn't just sitting at home. And that's the community that is supported by us but doesn't live with us. Separate from that, Community Living Toronto specifically, we have about 300 or so people who live in our group homes across the city. And our group homes are everything from single family homes, attached homes, detached homes, et cetera, all over the place, where people are supported by our staff, Community Living Toronto staff, for various activities of daily living. We've heard a lot about that already, so I'm not going to go into it at length, other than to say that in those situations, the people living in these group homes would have been also relying on these state programs or activities in the community as a way of getting out in the home and engaging with the broader world around them. So in my view, we've got a bit of a powder keg situation on our hands, where you have a lot of people who are stuck at home. People with intellectual disabilities tend not to be so good at changes in routine. So people who got used to going, say, to Tim Hortons every Tuesday morning or going grocery shopping with their mom and dad on Thursday afternoon, now they're stuck at home without that regular routine that they were used to. As an agency, we also have unique challenges around the fact that we have, as I say, about 300 people living with us. With that comes challenges around personal protective equipment that everybody is facing, both for the people we support, the ones who live with us, and for our incredibly dedicated, absolutely heroic frontline staff who have been deemed essential services by the province, essential workers, excuse me, by the province, and are out there on the front line alongside doctors and nurses doing critical work every day. So personal protective equipment, both for the workers and for the people we support, is obviously an issue. We, as a system of agencies across the province, we have been incredibly blessed with a government that has been quite responsive to the needs of agencies. So we've spoken to the minister and his staff on a number of occasions, and they put forward new resources to help agencies cope with this new situation, both around access to PPE, protective equipment, but also additional staffing needs and new program needs, et cetera, that have come on as a result of this. But I'll come back to this powder keg situation. To me, this is the issue. The agencies are starting to stabilize around how they're handling situations in their homes. And access to PPE, as always, remains an issue. Access to testing, et cetera, remains an issue. We've had situations where our staff, our advocates, have had to fight literally person by person across the sector. If they go into a testing center or if they go into a hospital, to have their worker with them. Sometimes it's an issue with paramedics and emergency.
Okay, let me clarify this, James.
Yeah.
So what you're saying is a person with an intellectual disability has to go for testing to see if they have COVID. They need to go with a worker who works with them because they can't go on their own. They need the supported assistance, and yet they may have an EMT or others saying, "Sorry, you can't go in. We have a protocol that says only one person comes in."
Yeah, and this has been community living type organizations across the province have been dealing with this kind of on a case-by-case basis. And I'm very happy to report that in many of the cases that I've heard about, the EMTs kind of see reason and say, okay, you can't necessarily come with us in the ambulance for probably very good public health reasons, but meet us at the hospital and we'll meet you there and make sure that you're available to provide, be it the interpretive services, but also the other care support services that somebody with an intellectual disability might need.
But it's a one-by-one incident of whether they get in or they don't. And
Precisely. And it varies by...
We need a provincial directive that removes that barrier without having to battle one at a time.
And it has varied by public health unit across the province. As I say, we're in this particular situation, we're in regular contact with the province on how to deal with these issues as they crop up on the ground. So this, we're working on this one as well from an advocacy perspective.
Right.
On the powder keg situation though, and I know, David, you're going to ask me about recommendations to government on things that can and should be done right now. It seems as though this is our reality for a little while, right? That we're all going to be living under some sort of physical distancing, quarantine, social isolation for some period now. And I worry, and agencies across the province and parents and their kids and loved ones all worry about the impact of not having these day programs or these respite programs in people's lives. So the recommendations I'd make to government, number one, we need to start thinking about sort of an online approach to day programs. All right, so and there are issues of equitable access to internet and equitable access to technology and other things that we need to sort out along the way. But the province has made enormous strides in making distance learning work for not every kid, but a lot of kids. I think it's time that we turn our minds to making a similar sort of platform available for people who are stuck at home with intellectual disabilities to have things to do and have at least some of the kind of stimulation that they would have had under normal times out in the community. There's a great website I'll plug for, connectability.ca. That's really, really good as sort of a clearinghouse for a bunch of different resources. And I think it's a great building block to start from.
And a recurring theme here is if the government can pilot something, then each organization, each family, each community living organization, provider, etc., doesn't have to reinvent the same wheel at greater cost, greater inefficiency, and taking much longer.
That's right. And the other thing is that there's a lot of variation in capacity in these agencies across the province. So I don't think it's fair, say, to ask a small agency in Northern Ontario to provide the same sort of resourcing and online provision that, say, a large organization like mine can, because we have access to the resources and the staff and the other things. So,
and the fact of the matter is, if it's being done remotely anyway, it may be that people in larger centers, and we've got people stuck at home, including the workers who used to provide the day programs, we could mobilize them again if it's done centrally to help make it happen efficiently.
That's right. That's right.
Carry on.
On a similar vein, I mentioned respite. So for those of the folks on the line who aren't familiar, respite can either be respite for a family member, which is to say a break from the regular caregiving tasks associated with being a mom, dad, daughter, etc., looking after someone, but it could also be a break for the person receiving care. Community Living Toronto and many organizations like us offer respite in our homes and in our various sorts of facilities to give families a break. As I say, those have been temporarily shut down because of the crisis, again, on public health grounds. But again, if this is to be our new normal for a little while, I think there are ways to do respite. I'm not the guy to design it because I'm not a public health expert or an epidemiologist, but smart people who know how to work with the social distancing, the 6 feet apart and all that kind of thing. We need to put our heads together to figure out an approach to respite that gives families and the people they support a break without compromising their health and putting them at risk. I know the way to do it, and I think we just need to turn our minds to making that work.
Some of those ideas may come from our later speakers, not talking in this context, but with ideas that we can borrow from. James, thank you very much. Back to Laura for our next guest.
Okay, thanks again for joining us, James. Our next guest is Thea Curdy. She's the Vice President of Designable Environments Incorporated. They help people achieve better levels of accessibility for the built environment. And I think we'll probably start by asking Thea to explain what that expression means. So Designable Environments advises governments and private organizations on how to ensure that their buildings are accessible to people with disabilities. Last fall, she and David appeared together on a widely watched episode of The Agenda with Steve Paikin. Thea, thanks so much for joining us today.
Thank you so much for having me.
Thea, welcome aboard. We're not talking today about how we should rewrite the building code, though it's long overdue, or what accessibility standards should be enacted for the built environment, though it's also, frankly, extremely long overdue. We're not talking about going out and designing new buildings tomorrow. Right now, the government's facing a crisis. They've got to establish some new urgency-based healthcare centers, either where they're going to deliver healthcare because of the overflow in our hospitals, or where people who have contracted the disease can be at least collectively isolated, so they're not giving to other people. What kind of practical ideas do you have or recommendations the government should take into account when they're deciding where to go or how to set these up so that the built environment is as accessible as they can achieve given their crisis situation? Take it away.
Well, yes, well, as you say, it's about alternative solutions, not about building new. So if we're going to be looking at different facilities, and whether that's for more COVID-19 assessment centers or hospital facilities for long-term care relief, shelters for the homeless, shelters for those who need to escape domestic abuse, which are sadly on the rise, respite centers, or even prisons. These are facilities that the government has to go out and find. So better options for expansion or moving people include rehab centers. They are some of the most accessible health facilities that we have in the province to date. Unfortunately, hospitals themselves, or healthcare centers outside of hospitals, healthcare centers themselves, haven't really had very good accessibility built into the building code. So unfortunately, we find there's a lot of barriers within the healthcare system. And if I can explain that, that's because typically the thinking around healthcare accessibility has been, well, there'll be somebody there to help you. And as we're seeing right now, there just isn't the staff to help the people that we have. So it really does rely on people for as long as they can helping themselves.
Let me just explain, Thea, let me just explain or elaborate here for our viewers. To many people, it may seem absurd in the extreme, because it is, that we have hospitals that do not have fully accessible built environment, both old ones and brand new ones. But it is the case. And in fact, the AODA Alliance has been in the lead in advocating for improvements in this area. And if you go to aodaalliance.org/healthcare, you can see not only what we've done to campaign for this, but that we've released a comprehensive framework for what accessible healthcare would look like. And one of our strong recommendations is the places where healthcare services are delivered should be accessible. But what you're saying is don't count on hospitals right now as being the right place. So you're talking about, if we have to expand to new facilities, you mean rehab facilities, which ordinarily would be places that are delivering rehabilitation services, but probably right now are shut down or largely shut down during the COVID crisis.
Right. And then in addition to that, outside of it, we've heard a lot of talk about using hotels. Hotels do have some accessibility, but not 100% of hotels are accessible, or the rooms are not accessible. They tend to have a percentage. US chains for hotels may be a better solution for government to be looking at, because they've had the Americans with Disabilities Act for the last 30 years. So in many cases, their policies and the way that they design things are a little bit better. We've also heard a lot of talk.
So there's an irony here that, in fact, here in Ontario, if you're looking for a hotel that's accessible, you may do better by looking at an American chain because of what Congress did better than what Queen's Park has done for achieving accessibility in our own province.
Right, and they've had it for longer. So that's not necessarily always the case, but if, like, as a general guideline, if I was going to recommend the government to be looking at, there's some specifics I'll get into about things to look at in facilities, but in terms of just generally, we're also hearing that university and college student residences and dorms are being considered. This could also be a pretty good solution because many of them are new, and the newer ones do have better accessibility accommodations for people. And then the other sort of extreme, as we saw in 1918, was the addition of tents. As we start getting into the summer months, perhaps sort of creating sort of tent cities for people. And that has some really good possibilities, but some unique accessibility solutions. Places you might want to avoid if you're trying to isolate people are things like gymnasiums and community centers. I mean, they're not being used and that's a big open space, but how do you really achieve proper social distancing, and particularly with all the shared washroom facilities? And the other place I'm seeing that I'm concerned about are convention centers for the same reason. They're not being used. There's lots of big open space, but convention centers in particular don't really have a lot of accessibility facilities because that's not their focus.
So give us some practical recommendations. You talked about tent cities or other measures that governments could take when they're setting these up, or they're not just when they pick them, but when they actually set them up so they can try to optimize their accessibility.
Right. So if you're looking to select a building or create a tent city, I have 10 simple things that I would recommend government be looking at to provide. Or make sure is in existence in the facility. So the first one is making sure that there's a covered and protected drop-off area for people immediately next to an accessible entrance. This reduces the travel distance, especially for people with disabilities who are coming to the hospital because they're very ill. They'll be fatigued. Everybody, even people without long-term disabilities arriving, are going to be fatigued. And the person who's dropping them off may not be allowed to go help them to take them to the entrance. And given how busy things are, the staff may not be able to help them either. So you want to make it very simple and close. For the entrances themselves,
Let me just explain, by covering it, it means that if they're moving slowly and it's raining, they don't get rained on. And also if they're moving slowly and need to rest, having some chairs along the way, even though it might seem to others to be not that long a distance, for somebody who's got COVID, who's got low energy and respiratory issues, they may only be able to go a few meters and need to sit down before they proceed further.
Right, and that would be even more important if the drop-off area isn't immediately adjacent to the door. Very good point. For entrances themselves, you want to be looking for an entrance that is level. You don't want to have to try to navigate stairs, obviously, or a big long ramp. You want to have automatic door openers. The power door buttons that we have are pretty good, but people don't want to be touching things. And we never want to use the wave at button technology because they're just not accessible to far too many people. We want to make sure the doors themselves have a wide enough entrance. And by wide, I mean a minimum of 3 feet or about 900 millimeters. And then the best practice being 4 feet wide or 1200 millimeters for those who have larger equipment or who are just larger people. Number 3, we want to be looking at obviously an accessible path of travel that allows people to have the social distancing, the 6 feet we're asking for. I'm also seeing, like in grocery stores, I really think we need to start thinking about corridors that are perhaps one way or aisles that are one way, because I'm getting people passing me in the grocery store and I'm thinking, like, I'm 6 feet from the person in front of me, but the person's passing beside me or behind me, obviously not understanding that distancing.
And that is such a great example, Thea. When people talk about the built environment accessibility, some people have this stereotype that it all costs millions of dollars, which is false. But just deciding in a grocery store to make the lanes one way costs nothing other than the sign.
So simple. Exactly. I love it.
Okay, yeah, carry on, Thea.
Yeah, no, that's fine. You want to make sure that if you're going into, say, for example, a hotel is an option, or any place that you're going to be coming into, you're going to need to have a reception area to welcome people and often to be sort of safeguarding the entrance. You want to make sure that it's very well lit so that things like Barbara was talking about for communication, people can see very clearly people's faces. One of the problems with the masks that we're wearing now is I'm seeing some innovation where people are cutting out the mask around the mouth and replacing that with plastic so that you can see the smile or see the lips moving. I'm a little bit hard of hearing and I often rely on lip reading. So that kind of simple accommodation, but needs to have good lighting as well. They also have to think about portable assistive listening equipment. So people who are wearing hearing aids typically have a T-coil switch, and there's portable equipment so that somebody who's trying to communicate with them, they can hear it very clearly above machines that may be beeping or other sounds that may be happening in the vicinity. The fifth thing I'd recommend is make sure that there's tactile signage. So again, if you're moving into a hotel, for example, this may already be provided, and you want to make sure that there's Braille both on any signs that are provided or elevator buttons.
And that has
so
to be,
people
that
have a
has to be
level of autonomy.
sanitized, because we blind folks have to touch it, but still we can even use, wash our own hands after, but that's our ability to operate those buttons.
Right, autonomy, respect, dignity, and because we just simply can't wait for people to help other people. There's just too many people needs right now. So if somebody needs to get up and find their way, they should be able to do that. The sixth thing I'd recommend is maneuvering space and the clear floor space next to seating. So if there's any place that somebody's going to have to wait for a test or wait in the waiting room for a room to be made available for them. So we need to have space for the assistive equipment they may be using, and of course, clear sight lines for those with hearing loss and cognitive disabilities to be able to see what's going on, or somebody may be calling them. The seventh thing, obviously, is the washrooms. People get washrooms wrong all the time. So if you were going to assess a building to see, you're looking for power door operators for the doors if you can, a large door, a clear space beside the toilet for assistive equipment, grab bars that are both placed behind and beside the toilet to help people independently transfer. And again, all of this will need to be cleaned, of course. Making sure that, of course, your accessible soap dispensers and accessible sinks are provided, and automatic paper towel dispensers versus the hot air blowers. The hot air blowers have all kinds of infection problems. They're loud and they're upsetting to many people with cognitive disabilities or people with hearing loss or vision loss. So,
and they probably are they're spraying the infection from your hand all around the room.
No kidding.
Let me just
sensory hell for people with autism.
They're compromised immune deficiencies. Yeah.
Let me just emphasize. I've been seeing on Twitter day after day. We fought for accommodations like automatic taps and sinks and so on as a community for years, and of course the pushback has been, oh, it costs too much. But right now, I'm sure everybody who goes into one of those washrooms who doesn't want to get COVID wishes that governments had listened and had required these in public washrooms, because they are now a measure that protects all of our health and safety. Carry on, Thea.
Right. Yeah, and soap dispensers and paper towel dispensers, all of those things can be automated so that nobody has to touch anything, and it reduces how much cleaning and obviously how much work the important support staff are doing. The other thing I would talk about is in tent facilities. So if you're going to be moving outside, then you're going to be needing to have porta potties for people to go to the bathroom. And I would recommend you make sure all of the porta potties are accessible. And you're probably going to need some with adult change benches in them, although people sometimes are changed in their room, sometimes they're not. And if you don't have 100% of them being accessible, I mean, if you think about it, when you're in the hospital and you're that sick before you get put on a ventilator and can't leave your bed, waiting for a staff person to come and take you to the washroom when you're weak and don't have a lot of stamina probably isn't going to happen. So you're going to need to be self-sufficient, and that's one of the only ways you're going to. And of course, some staff members have disabilities, so at least one of the staff washrooms in every area should be accessible or an accessible porta potty. The eighth thing is the bed transfer height. So when people talk about, well, we can go move into a hotel, a lot of
sorry, Thea, you just cut out. Just say that again, please. Thea, your signal's cutting out.
Some hotel rooms are, yeah, sure. So okay, I'll try that again. So the bed heights are typically too high. So one of the simple things you could do that wouldn't cost a ton of money, it will cost some, is replace the bed frames in the hotel rooms so that they have a built-in structure, sort of like an IKEA bed, has a built-in sort of box spring as a part of the frame, and then the actual bed itself can sit lower down, and people again can independently transfer. And that of course means that you need to have space beside the bed so people can keep their assistive equipment and can move around independently. The number 9 example would be, and this is a personal thing. My great-grandfather went into hospital a couple of years ago for some tests. He was 90. He was in an unfamiliar situation, woke up in the middle of the night, and there were no plug-in night lights. And he tripped and fell and sustained a head injury and died. So it just occurs to me that a simple plug-in night lights that are on motion sensors would help people in strange surroundings find the washroom or get up or call for help or whatever it is that's happening, particularly when they're confused or weak.
Again, government could order a batch of those, bulk order them fast if we need to.
I mean, they've got them everywhere.
All right, carry on.
And the last one is 10, hand sanitizers and soap and paper towel dispensers absolutely need to have the space to get to them, the clear floor space in front of them, and be at a reachable height from a seated assistive device position. I can't tell you enough, they're not color contrasted. People who have vision loss have trouble finding them, and people with assistive devices can't even get to them. For a sink, it's even better that the soap dispenser is on the side wall and not on the back wall where you have to reach all the way over the sink to get to it.
Thea, your ideas are really helpful, practical, and doable, and I want to thank you very much. I want to alert our 4 remaining guests that we are actually going to be short of time. We're going to get you all in, but I'm going to move you through your important content quickly, even though I'm not in any way undervaluing the importance of it. Back to you, Laura, for our next guest.
Sorry, just forgot to unmute. Thanks again, Thea. All right, we're going to look more closely now at the issue of surviving this crisis for people living in poverty. Our next guest is Yola Grant. She's the acting director of the Income Security Advocacy Center. Thanks again, Thea. All right. Oops, that's a community legal clinic, provides advice, advocacy, and representation to poor people seeking income to live, such as those on ODSP. Thanks for joining us, Yola.
Hi, Yola. Let us know, we all recognize that everybody's under financial hardships now, but for people living in poverty, disproportionately people with disabilities live in poverty, and disproportionately people living in poverty have disabilities. Can you talk about the particular hardships they're facing? And you've got a few very concrete examples or recommendations that government could take to help alleviate that hardship. So take it away, Yola, and thanks for joining us.
Thank you, David, and thank you to the other organizers for inviting ISAC to participate. As we're running short of time, I want to cut quickly to the chase. Our website is incomesecurity.org. I repeat, incomesecurity.org. And there you'll find today's press release and an open letter to the Minister of Children, Community and Social Services that lays out our concerns about income support programs offered by the province, but also those offered by the feds that we fear might be clawed back by the province. This pandemic highlights for us an urgent need for paid sick days, a more inclusive employment insurance program, and a more robust social assistance program. We take the view at ISAC that no one should be left behind, and this pandemic provides us with an opportunity to focus on some long-standing changes that we've been asking for. With respect to social assistance, that includes Ontario Works and Ontario Disability Support Program, we've been asking for the rates to be increased. They are currently woefully inadequate for a single person on Ontario Works. It's $7.33 per month. For someone on ODSP, it's $11.69. It's a bit better, but it's still well below the poverty line that in Ontario is established at $1,767 per month. And you can imagine for people living in expensive urban centers that this causes significant hardship. For someone to receive ODSP, they need not only be poor, have a financial need, but they need to have a substantial physical or mental impairment that is expected to last at least 1 year and leads to a significant restriction in activities of daily living. It's hard to say this early on whether this virus, COVID, will lead to an increase in the ODSP roles in future because of this 1 year lag that's actually built into the legislation. Raising the rates, however, right now would provide for immediate relief for those already living below the poverty line and who are challenged by increases in prices that most everyone has experienced in the last few weeks. But it would also have an added benefit of becoming more inclusive and permitting people who now hover just above the abysmal rates, but who are below the poverty line still, it would now be broadened to include some of those people. So we are pushing strongly for an increase in the rates for social assistance. There's been some talk of providing discretionary benefits at the provincial level, but no guidelines have been given. And
so by discretionary benefits, that would mean someone who's already qualified for ODSP, for example, might be able to ask their individual caseworker to give them
correct.
a discretionary raise, but then they'd have to make the case one by one, which would be a
Correct.
ton of work for a whole lot of caseworkers who will be overloaded.
Exactly.
What's the better solution?
We take the position that discretionary benefits are uncertain, hard to access, and limited, so limited that they're not really meaningful. A better approach is simply to raise the rates across the board, which is transparent and a longer term solution. The second income support program I want to address is the EI benefits. There's been no change to the regular EI benefits, but for people who become sick because of COVID, there's been a slight improvement to permit people to obtain benefits immediately without a 1 week waiting period. The concern with EI, of course, is that it covers you up to 55% of wages, and it's capped at about $753 per week. So it's actually not terribly much. It too is inadequate. And we would, at ISAC, we've asked for and have had others support this view that the rates should be increased to be more representative of a wage replacement program on which someone can exist. We also ask that it be expanded so that workers in our economy today who are undocumented can be covered by EI. Currently, we have many undocumented people in our society who are workers or who are poor and who are not entitled to a significant number of benefits, for which they, contribute through taxes. And my third area that I want to cover very briefly is the new Canada Emergency Response Benefit that was announced on March 25th. And this has been in the news a fair bit. While it's a positive and somewhat universal program, it's not good enough. It provides a taxable benefit of $2,000 per month for up to 4 months for people who've lost income because of COVID-19. The problem is for workers who have reduced hours or reduced income, they're not covered, or anyone who's had income in the last 14 days. So people are disincentivized in continuing to work and to provide supports, even people who provide social work or mental health support.
Sorry, I need you to repeat. I need you to repeat your last sentence because your signal just broke up. Sorry, Yola, your signal is now dropped. There you are. Yola, can you just start again? We've lost about a paragraph.
Continue to
Bruce, I don't know if there's something we can do to strengthen Yola's signal. Yola, we've lost you. We're losing.
5,000 the last year. To ODSP, who typically some people.
Okay, I'm sorry, Yola. I don't know if you can hear me, but we've totally lost about the past minute of your content. I'm sorry, I think we're going to have to wrap up with Yola, but we encourage you go to her website. Laura, I'm going to go back to you in a minute for our next guest. Oh, you're back.
I'm back.
Okay. Give us the last minute again, and then we're going to wrap up and move and keep going.
Correct.
But if you could just summarize the last minute again, I'm sorry.
Just very quickly, for people who are receiving disability benefits through ODSP and who also work, are able to keep some of their earnings. However, if they become unemployed, that money is clawed back at 50% rate. And with the CERB, the newly announced benefit, the concern remains that this might be clawed back as well. We've asked the Ontario government to take a position on this, to agree not to claw back this benefit so that it is truly universal as was intended by the feds, and they have not yet responded. We know that in BC, that government has provided that assurance about 2 or 3 days ago that it will not claw back the emergency support benefits. And with that, I will urge everyone to go to our website to see our written material regarding the open letter to the minister, as well as our critique of CERB and other programs.
Okay, thank you very much. Back to Laura.
Thanks so much, Yola. And we'll add your website to ours. We've got a resource page for on the OAC page as well.
People go to the Ontario Autism Coalition website. We're setting up a resource page with show notes for today's program. Laura, can you just give the website for the OAC?
Sure. It's ontarioautismcoalition.com/COVID. So we started off creating a resources page specific to people with autism, but it's very quickly becoming links that will help people with other disabilities as well. So thanks again, Yola. We're going to turn next to Lana. Is it Lana or Lena Fredo? Lana, thank you so much. Sorry about that. This is a really important conversation. Sheltering in place is hard enough if you have a home to shelter in, but what about people who are homeless? So Lana is the executive director of Sound Times Support Services. It's a community mental health agency wholly operated by people with lived experience. It provides advocacy and support services in the area of mental health, addictions, homelessness, and in the criminal justice system. Thanks so much for being with us.
Lana, unfortunately, we have less time than we thought we'd had, and the topic you're dealing with is absolutely critical. So I'm going to just throw it over to you and say, tell us about the big hardships, give us your concrete recommendations, and please describe some of the measures you've taken in your organization, which are very impressive and which others could replicate at little or no cost at all.
Okay, sure. I'll be quick and just hit some high points. So my biggest concern is that the planning that's being done for individuals who are homeless make an assumption that individuals who are homeless are a monolithic group. Our best estimates, we know that within the population of individuals who don't have secure housing, 45% of those individuals have disabilities. And among that 45%, the vast majority have what I'll broadly call psychosocial disabilities. So my concerns are that without dedicated support, those individuals will not have equal access to testing, to healthcare, and to public information. I'm also concerned because of assumptions about capacity and an individual's capabilities that they will be excluded from preventative interventions. And then finally, there is a concern that public restrictions based on public health directives and the actions of law enforcement and security personnel will discriminate against individuals who have psychosocial disabilities. So very quickly, the things that I would recommend. I guess my overarching recommendation sort of follows on what Barbara and James said. I realize that the government is in crisis mode and everything is chaotic, but I do think there is something to be said for leaving 85% of those resources to manage that, but to cleave off something where there's some leadership. There's some leadership in order, maybe interministerially, to plan to ensure and enhance the continuity of the services that we have by realigning or repurposing the existing resources in the system. Because what we have now is a whole bunch of people working full throttle, but a whole bunch of people who don't have much to do. And there needs to be some coordinated plan to ensure that our resources are exploited as best as we can. And with that, I'm hoping particularly for the group of people who are homeless both sheltered, and we're not talking about unsheltered people. And where I'm sitting right now, I'm downtown Toronto at Parliament and Shooter. There's a small tent. Hasn't reached city status yet, but there's a small tent village has sprung up in a giant lot that once had a school. So those individuals living in those tents, people in that situation are of particular concern. How will we ensure equal access to water, food, shelter, and washroom facilities? And so I really feel that some of the resources we have now could be redirected to those ends. Also, we need to realign some of the clinics and distribution of medications so that individuals have voluntary access to medications. And we could ensure the continued provision of harm reduction services and opioid substitution therapy, because right now those services are strapped, and existing resources that we have in the system who are knowledgeable about substance use could be realigned. And also, finally, we need support for community providers who don't traditionally work in medical clinical contexts. We need support with PPE and proper education vis-a-vis infection control.
Now, you talked to me, I just want to take 1 minute to have you describe what you're doing at your center. You're a community mental health center, and you've said that you need direction from the government to help coordinate the work of community mental health centers.
Yes.
So they're not all left on their own. Can you just take a minute to describe what you've done? Because it's excellent. And I think the government should be helping other community mental health organizations do the same if they're not already doing it.
So Soundtimes has about 3,000 people who use our service, and about 70% of them are of no fixed address, and they don't have a lot of access to technology. If they do have phones, a lot of them have phones, but they're sketchy, shaky plans, or they have to conserve. So what we decided to do, since a lot of organizations were talking about doing virtual case management and virtual support, we were trying to figure out how that would work. So what we've done is we've closed off our the section of our building that we use for the resource center. There are some dedicated staff there who are vigilant about hygiene and PPE, and the rest of the staff are in another part of the building. We've set up these kiosks so that individuals can come in and meet face-to-face through the laptop with a worker.
So they come in the front door, they sit down at a kiosk.
There's screens,
You've got a laptop. They don't need to own a laptop or have any internet services.
No, and it's a very, very simple, interface, and they can be talking with a worker who is sitting upstairs. And then that way, if any document, if it's an "I didn't get my check" conversation, if any documents need to be produced or they need to give us any documents, we have a document center set up. We also have a lot of people who use us for their mailing address. So we've been able to do many, many things. Advocacy initiatives, we've been doing people's taxes. We've been doing a lot of things through that interface, which is quite simple. And I've set it up with our own existing technology.
So you didn't have to buy new computers, and you've got kiosks that are spaced enough from each other so that nobody's getting exposed. Lana, I'm sorry, I'd love to do more, but I've got 2 more guests to get to, and we're running out of time. So thank you so much. I want to, as Laura, as you're getting ready to unmute and bring in our second last guest, I just want to emphasize to everybody, there are more barriers than we're covering. There are more disabilities than we've been able to fit in, but we're doing the best we can. Laura, over to you.
All right. So we're going to turn now to a situation close to my heart as a high school teacher, and that's the situation facing hundreds of thousands of students with disabilities as schools, colleges, and universities have all shifted to distance learning. Our next guest is Karen Mccall. She's an expert on making digital documents and other content accessible to people with disabilities. She's adjunct faculty at Mohawk College's Accessible Media Production Program, and she's also the owner of Carlin Communications. Karen, I want to start with a question that came in some time ago from one of our viewers, and then let you go to talking about barriers and your suggestions. the question was, is there any data indicating how many students with special needs have access to a computer and high-speed internet at home?
No, there is no real data. It's been one of the problems both in Ontario, Canada, and internationally, is that there isn't a lot of data on this information.
Okay.
I know in primary and secondary school that often computers that are available at school are not allowed to be taken off of school premises, which then limits access to computers.
No, Karen, it's David. We're going to do this in about 2.5 minutes because we're short on time, not because the topic is unimportant. We know that some school boards and other educational organizations are trying to get equipment to families so they can connect. But as schools, colleges, and universities move to online teaching, virtual classrooms, sharing things online where you download, read, and do your assignment, can you talk about the barriers facing people with vision loss, dyslexia, or other disabilities with digital inaccessibility? And can you give us top recommendations for the government to make sure those barriers are torn down just as we're moving to this online learning world?
The largest barrier is that the digital content and the tools are not accessible, which means that just because they're on the screen doesn't mean that the adaptive technology like a screen reader or text-to-speech tool is going to be able to read it. You have to use standard fonts, you have to describe images. So there's a lot that goes into making sure that digital content is accessible in terms of the software and the applications, having keyboard access. So imagine not being able to use a mouse or a monitor. How are you going to access the information? And that's where we start looking at the accessibility of digital content. Just because you can see it online doesn't mean that someone can use their technology to read it back to them.
And just to give it, can I give just an example? Last night, and I cut Toronto District School Board a lot of slack. They're dealing with a crisis, but we had a meeting of the Special Education Advisory Committee that I'm on. We're using Zoom right now for this meeting. It is very accessible. Instead, they used another product, Google Meet, which has, let's just say, way less accessible as far as I could see. Your choice of your tool that you use may create barriers. Can you give us some concrete recommendations for the province so that each school board, each college, each university doesn't have to reinvent the wheel? We've had regulations on the books for this since 2011, but those regulations are out of date. They don't cover mobile apps. They're not effectively enforced, and too often they haven't been fully implemented. We're not saying nobody's doing anything, but what can be done to make sure that all of these organizations are doing the right thing? Karen?
Not to be too personal, but I get my best ideas in the shower. And this morning I had what I think is a really good idea. So I contacted Yuta Treviranus of OCAD because OCAD, the Ontario College of Accessible Design, is uniquely positioned to be the central repository for strategic planning, for training, for document accessibility. They can vet vendors and people who create accessible documents as their business, and they can then work with the schools to make sure that their information is accessible, but having everything housed in one place and deployed from one place so that you do have a standard of excellence, a common standard of this is what an accessible Word document is, this is what an accessible PowerPoint is. So you're not getting a lot of variations, I think is the biggest recommendation that I would make to the provincial government is to work with OCAD and allow them to work with the primary, secondary, and tertiary education.
And at this point, we realize that we won't get all the results in the first week, but as we're getting into a process that could go on for weeks, they could be rolling out tools that will ensure that these barriers, which have always been there, aren't slamming the door on students with particular disabilities at this critical time.
Well, this is the thing. I mean, COVID-19 will come back in the fall. I have no doubt of that. And then there's another pandemic on the horizon. So right now we have a 4 to 5 month window that we can start implementing this and at least when this comes back again and students are confined to home to learn, we've had a good start on making the content accessible.
Thank you so much, Karen. Laura, we're going to go back to you in a minute. And if we could bring in our final guest, if I can just warn everybody, we may go 1 or 2 minutes over 12 o'clock, but that'll be as much as we do. Laura, back to you.
All right. So we're going to continue on in this segment with a focus on children and youth with disabilities. Our next guest is the extraordinary Irwin Ellman. He works now as a special advisor to the Laidlaw Foundation. He was previously Ontario's child and youth advocate. David and I may jump in here to share some of our thoughts on education for students with disabilities. But Irwin, thanks so much for joining us.
Irwin, thanks so much. And I'm sorry we have less time than we thought. It just means we've got to get to our recommendations as soon as possible, especially we've got hundreds of thousands of kids, children and youth who are facing added barriers in the education process. Your top recommendations for government. You go first. I'm going to go second.
Sure. Let me just say everything that people have said so far is amazing, but it also is important to remember it all applies to children and young people. So all of those recommendations are important for children and young people too. What I would say, if I can, is that I think government needs to backstop our communities in the same way that they backstopped our businesses. We need to take the same approach. I wish communities come first, but we have said to business, whatever you need, you will have. You are important to us. We value you. And I think we need to do the same thing in our communities. We need to say to every organization in our siloed sectors, whether it's the disability sector, child welfare, youth justice, whatever, in our communities, you will have whatever budget you need. And we need to encourage them not to move away from our children and youth, but move towards them. We need to understand their first responders. They need to have the PPE to do their work, to move towards children and youth. But we also need to say that to community organizations. There are community organizations ready and willing to be of support to children and youth with disabilities that in their communities, organizations like the Boys and Girls Clubs in Ontario. But I've run out of funding. Don't have funding to do that work. We need to say to them, whatever you need, we've got your back. Do what you can and do what you need to do to support children and youth and their families in your community. And we need to say, don't worry about your budgets. That will come later. This is not about silos. It's not about accounting. It's about taking action. And I think that's the attitude government needs to have. And with that attitude, we can begin to do not all the overwhelming work that, because it seems overwhelming, I think, after 2 hours of listening, but there is so much we can do, and we need to use that attitude. It's not we can't, it's not we're overwhelmed, it's how do we do this? And I think that's the attitude
Irwin,
we need to bring to bear.
Thank you very much, Irwin. I'm just going to throw in my 2 bits, kick it over to Laura, and then we're going to have to wrap up. This is a subject near and dear to my heart, as are all the other subjects. Over a week ago, the government announced that we are going to keep our schools closed, properly so, and that we're moving to online or distance learning. That's good, but they did not announce any plan or a commitment to a plan that we've seen of action to ensure that hundreds of thousands of students with disabilities are not second-class citizens. Now, school boards are scurrying to do what they can. I can tell you that last night at the Special Education Advisory Committee for the Toronto District School Board, of which I'm a member and past chair, a senior board official, I got to ask her, have you gotten any specific directions from the province on what needs to be done for meeting the needs of students with disabilities? And we were told, other than some general language, the answer was no. We need the government to not leave it to every school board to reinvent the wheel. We need the government to step up and lead on this. This is an example where they should be reaching out to us for advice and ideas. There are cores of people with lots of good grassroots ideas, and they aren't. As just one illustration I'll give quickly, we, the AODA Alliance, led the fight for years to get the government to agree to create an education accessibility standard, to create a map for accessible education in Ontario. Finally, we got action on it. At least the standards development committees were set up. I'm on the one for kindergarten to grade 12. they have not, the government has not asked our committee to just give them ideas on what they should be doing during this COVID crisis to ensure the needs of students with disabilities are met. They could set up a Zoom meeting. They've got people available. They've handpicked the people from the disability community and the education community with expertise. We actually had a meeting, a regular meeting scheduled for last week, April 1st. They canceled it. I understand why they couldn't do business as usual, but there's no reason why they couldn't have said, hey, how about if we take a couple hours and as many people who can attend virtually, let's brainstorm ideas. That was the day after the premier made the big announcement about education. Nothing as far as we've seen for us. And since we've raised this repeatedly on social media and publicly, the Ministry of Education, the Ministry of College and University still have not reached out to us to even start a conversation. That's got to change. Over to you, Laura. And then if you want to take us into our wrap up.
Sure. Erwin, I just want to ask you a question, because you and I got to know each other during that extraordinary time where we were working with a group called We Have Something to Say. What would you bring forward from the recommendations of that group that would help the Ministry of Education at this point to better support students with disabilities?
I mean, in this situation, what I think is really crucial, I'm glad you gave me this chance to say it, because young people would be disappointed if I didn't.
Right.
They want to be seen as more than their disability. I hear that over and over again. Right now, the young people, and I'm thinking of so many who are even the ones trying to live on their own, face barriers every day. I'm hearing from them, they're frightened, they're scared. They're listening to talk about the triage of healthcare, and they wonder what that means for them. And it tells them they're not valued. It tells them that they're not seen as more than their disability. And what they said in that report, in a whole bunch of ways, was when you take us seriously and listen to us and talk with us and ask us what will be helpful, that's when we start to feel valued. I mean, that's true of all human beings. What I would ask to do immediately is to bring, I mean, and I'm shout out to Elspeth, and shout out to Cliff and Clara. I think we can hold a town hall for government with young people with disabilities to say exactly what could be done for distance learning right now for people like them. And I think there is no substitute for teachers reaching out and teaching within relationship to both parents and with kids. And I think the start is in dialogue, and I think we can learn as educators about what we could do, but in doing that, young people learn as well.
Listen, those are all fantastic ideas. Laura, just as you move to our, thank you so much, Erwin. Just as we move to our wrap up, I want to alert our sign language and captionists who've been doing an amazing job. We're going to finish within the next 5 minutes. And I just want to emphasize, we know that folks at the government are working as hard as they can. And we know that people at school boards and colleges and universities are all scrambling. So again, we realize what they're facing, but we know that without a plan, and a dedicated focused plan to meet the needs of students with disabilities, we're going to face more problems. And we want to make it more successful by avoiding the need for them all to reinvent the same wheel. Laura, over to you.
All right. Thanks again for joining us, Erwin. And I think one last recommendation I think I would be confident bringing forward from youth with disabilities is that they're very nervous that if they get sick, they'll be asked to go into the hospital alone without a parent or an attendant to support them. So I think one recommendation we would make would be on that point. So David, let's bring this home. What should we learn from all of this? What are your concluding thoughts?
I'd like to offer just a few short conclusions, but they're really important. The first is, one thing people with disabilities know from our bitter experience is that we get forgotten unless we push hard to insist that we be included. Not because people have anything in for us, but because time and again, we just get forgotten, or we get our needs don't get addressed. The fact is, the needs of people with disabilities, the urgent needs, such as those covered in this forum, will not get effectively included in emergency planning unless government leads unless a government focuses specific efforts and makes it a priority to include concrete measures for us. Now, again, we're not saying they're doing nothing, but we don't know what they're doing because they're not talking to us other than the conversations a few of us had informally with just some, like at the Accessibility Ministry, but the key players are not. The Premier's office is not, Cabinet office and so on has not been talking to us at all. And we're there to help. We hope that this will be the first word, but not the last word. The provincial government held a news conference just a little over a month ago on February 28th, proclaiming proudly that it is leading by example on accessibility. Well, we need them to start doing that here, not just say it, but do it. They said they're taking an all of government approach on accessibility for people with disabilities. We need that happening here. This virtual public forum is emphasized ways. So that's the first thing. The second is the government needs to talk to the experts, and the real experts on the needs of people with disabilities are grassroots people with disabilities. We're there to help. We've come up with great ideas, I believe, here from talking to some really good people. There are more people that can be talked to, and we're happy to facilitate it in any way we can. The third thing is a long-term message, and that is this. When this is all over, when we're back to life as usual, God willing soon, there are many lessons to be learned, not just about having more masks on hand for emergencies, so that's important in ventilators, though that's critical. But there's another lesson. We've had a decade of foot dragging by government after government, minister after minister on accessibility for people with disabilities and inclusion. We get these self-congratulatory claims about leading by example and so on, but the fact of the matter is the implementation and enforcement of the Accessibility for Ontarians with Disabilities Act is way, way behind. Had it not been behind, we would be able to tackle many of the problems we've heard about in this public forum, and to do so more effectively than we can now. So the lesson that needs to be learned is that the foot dragging has got to stop. It's got to stop, and there needs to be a bold, fresh, new approach with strong leadership on accessibility. It's not a partisan thing, it's a nonpartisan thing, and we've got to learn it. The final message I think we can learn from all of this is look at how the problems that have been addressed in this virtual public forum compound. You may get people with disabilities, some of them are more prone to get this disease. They can be more prone to suffer the biggest physical consequences of this disease. Because of policies and problems that we've identified, they may be more exposed to catching this disease because of some of what our presenters have demonstrated. And if they get to hospital, they're going to face more barriers to getting healthcare service. And God forbid, if we need to get to triage, there's a risk that the triage rules may wrongly take into account some disabilities in deciding who gets those emergency services. That compounding cruel set of consequences was not anybody's design. But when you're the victim of it, it's no less cruel. And so we need governments to act on these measures. We are delighted our presenters made concrete recommendations that are practical, even in a crisis, and we urge government to accept the hand we're reaching out to them, governments at all levels, and to work with us. Laura?
For sure. All right, so shout out again to our interpreters and the people providing the captioning. You've been amazing and patient. I want to thank CIBC for providing some of the funding for that. The OAC is covering some of it as well. To those of you watching, now that we've reached the end, you're probably thinking, what can I do to help? First of all, we want you to email, tweet, or Facebook message your MPP. Tell them to watch this video, since it will be archived on YouTube and it'll be available on our channel. We need the government to act on the recommendations that we heard today. If you don't have time for that, then on Twitter, follow at AODA Alliance and at ONT Autism, and just retweet our tweets. Make sure you use that hashtag disability urgent. You can bet that we'll be making sure governments hear our message through social media. Second, let the mainstream media know about the disability barriers you are facing during this crisis, like the ones that we've mentioned today. The media is properly giving tons of coverage to the COVID-19 crisis, but these disability issues deserve much more coverage than they're getting. Your stories will get their attention. Please phone, tweet, or email the media in your community. Stay tuned to the AODA Alliance and the OAC for more updates. To follow our activities and stay informed, you can sign up for the AODA Alliance email updates by going to www.aodaalliance.org and go to the sign up link. You can also go to the AODA Facebook page or to the OAC Facebook page. You can follow the OAC at ONT Autism. You can subscribe to our YouTube channel, and please visit our webpage at www.ontarioautismcoalition.com. And if you want our resources page, just add /COVID to that. Working together, we're going to be able to ensure that people with disabilities have their urgent needs met during this crisis and beyond. So I want to thank David and Bruce for all the work they did organizing this, all of our guests, and thank everybody for tuning in. David, bring us home.
I want to wish everybody safety and health. We will get through this. We are used to uphill battles. They don't deter us. If there's one thing about the AODA Alliance and the Ontario Autism Coalition, whether you say tenacity or relentlessness, we will keep on pressing these issues, working with all our partners and our supporters. We've done our best to ensure that the information we've provided is accurate. If we've gotten anything wrong inadvertently along the way, we're sorry, and we'll do our best to keep pressing these issues forward. Thank you all for tuning in. Please encourage others to watch the archive video. Stay safe, and wishing you all the best. Thank you all, and this brings to an end our virtual public forum today.